Hello, learners. Welcome to Lecture 20 about monitoring and evaluation of RCH programs in our series of public health policies and programs for RCH. In earlier sessions, we discussed implementation changes, management settings, community involvement, and public private partnerships. Today, we turn to monitoring and evaluation, which is the backbone of accountability and success and effectiveness of a program. Today, monitoring and evaluation help us to ask two critical questions. Are we doing things right? And are we going into the right direction? Are the programs successful? Are they giving proper outputs? And is there a change being brought about those programs at the peripheral level? We can assess all this with the help of indicators, data sources, and also in this lecture, we will explore how we connect these ideas to India's RCH experience and international goals, such as the Sustainable Development Goals. By the end of this session, you will be able to conceptualize and monitoring and evaluation framework and appreciate its role in planning better maternal and child health outcomes. Monitoring and evaluation are two distinct yet complementary processes. Monitoring is like a continuous checking of patients' vital signs, keeping track of activities as they unfold. It ensures that services are being delivered on time and as planned, while evaluation is more comprehensive and occurs at specific points to judge the merit, the worth, and the impact of the program. It helps us ask whether the design was appropriate, whether the outcomes were achieved, and whether the program was successful. When combined, monitoring and evaluation provide both short term and long term insights and corrections into the strategies of the program. For RCH programs that span multiple levels of care and diverse interventions, this dual approach is very essential. The importance of monitoring and evaluation in reproductive and child health cannot be overstated. The importance of monitoring and evaluation programs in reproductive and child health cannot be overstated. These programs are resource intensive and politically sensitive, and therefore they require transparent systems of accountability. Monitoring allows administrators to keep track of the progress towards national targets and international commitments like the Sustainable Development Goals. Equally important, it identifies gaps, delays, and bottlenecks before they snowball into major problems. Evaluation provides the evidence needed to justify policies and budgetary allocations importantly. Monitoring and evaluation helps uncover the inequities in service coverage, thereby guiding corrective measures that promote fairness and inclusion. By embedding monitoring and evaluation into reproductive and child health services, we ensure that policies are not just aspirational but actionable and measurable. Additionally, disaggregating indicators by age, sex, caste, tribe, wealth, quintile, and geography makes inequities visible and traceable. Real time dashboards built from health management information system and district health information software data enable rapid course correction in primary health center, community health center, and district levels. Linking outputs to costs through public financial management system strengthens value for money analysis and budget reprioritization. A clearly articulated theory of change and periodic process, outcome, and impact evaluations keeps these strategies evidence aligned. Routine data quality audits, maternal and perinatal death reviews, and client exit interviews ensure that numbers are credible and explain the why behind the trends. Public disclosure of scorecards, community walls, and Jan Sunwai, that is public hearings, creates social accountability and trust. Finally, an explicit learning agenda with after action reviews turns monitoring and evaluation findings into managerial decisions, training plans, and procedure fix and procurement fixes that improve RCH outcomes. I'll repeat this again. Public disclosure, scorecards, community walls, and Jan Sunwai creates social accountability and trust. Finally, an explicit learning agenda, which after action reviews turns monitoring and evaluation findings into managerial decisions, training plans, and procurement fixes that improve RCH outcomes. The objectives of monitoring and evaluation in RCH revolve around measuring both performance and fairness. One key aim is to assess the effectiveness of interventions. Are institutional deliveries rising? Are contraceptives being used more widely? And are infant deaths declining? Service coverage and quality are another concern, since high coverage with poor quality can lead to minimal impact. Detecting inequities is equally crucial because averages often mask detecting inequities is equally crucial because averages often mask the disadvantages faced by the rural women, the poor, and the marginalized groups. Evaluation findings guide rational allocation of resources by showing what works best. Finally, by systematically documenting results, monitoring and evaluation strengthens accountability both upwards to the policymakers and downwards to the communities who are the ultimate beneficiaries at the peripheral level. The monitoring and evaluation process is built upon a chain. The monitoring and evaluation process is built upon a chain of interconnections. Inputs are the resources committed to the program, such as funding, personnel, supplies. Processes describe the activities carried out, like trainings, outreach, service delivery. Outputs are the immediate deliverables, like number of antenatal care sessions conducted or immunizations given. For instance, increased contraceptive uptake or improved health seeking practices. Finally, impacts. Impacts are the long term shifts in population health, such as reduction in maternal mortality or decline in infant deaths. By organizing, monitoring, and evaluation across the chain, we can pinpoint at what level the program is succeeding or failing. While monitoring and evaluation are often spoken of together, there are differences in both the terms and which are important for grasping. Monitoring is continuous, routine, and focused on activities and outputs, while it provides managers with quick feedback and allows problems to be detected early. Evaluation, however, is periodic and more in depth, focusing on outcomes and impacts. It asks, whether the program was relevant, efficient, and sustainable. Monitoring might show that thousands of women attended antenatal care clinics, while evaluation would reveal whether the attendance translated into improved maternal outcomes or not. Both are indispensable. Monitoring keeps the programs on track, and evaluation tells us if the journey itself is worthwhile, if we are going into the right direction, and the program is being giving the impacts which it was supposed to give. A commonly used framework for monitoring and evaluation is the logic model, which depicts the programs as a sequence of linked steps, setting from inputs and moving to activities, outputs, outcomes, and impacts. For each stage, appropriate indicators are chosen to measure progress. For example, inputs could be measured by funds released, outputs by number of antenatal care visits, outcomes by contraceptive prevalence rate, and impacts by maternal mortality ratio. This structured approach helps managers understand how resources translate into results. Importantly, the framework is not linear but cyclical. Feedback from monitoring and evaluation should be fed back into the program redesign, thereby creating a continuous learning and improvement loop. To operationalize the logic model, define SMART. S for specific, M for measurable, A for achievable, R for relevant, and T for time bound. Indicators with clear baselines and annual targets. Specify data sources and frequency. Health management information systems monthly reports and periodic third party audits to ensure reliability. We can block the program manager, district program manager, so each indicator has an owner and a review forum. Document assumptions, map responsibilities across the levels like A&M, medical officer, block program manager, district program manager. So each indicator has an owner and a review forum. Document assumptions and risks. So deviations trigger mid course corrections rather than end line surprises. Disaggregate every outcomes by sex, age, caste, tribe, wealth quintile, and geography to surface inequities early. Link activities and outputs to a theory of change that makes causal pathways explicit and testable during evaluations. Use lightweight dashboards and data to decision huddles to close the loop from evidence to action each month. Finally, archive lessons as brief after action notes so redesign cycles for reproductive and child health become faster and fairer and more measurable over time. Indicators are measurable variables that tell us whether we are progressing towards our goals. In reproductive and child health programs, indicators span across inputs, processes, outputs, outcomes, and impacts. Input indicators may look at how much of the allocated budget was actually spent. Process indicators could capture the number of training sessions to the health workers. Outputs might measure the proportion of pregnant women receiving antenatal care. Outcomes could focus on contraceptive prevalence or immunization rates. Impact indicators finally look at long term changes like maternal or infant mortality. Selecting the right mix of indicators ensures that we capture both the quantity and the quality of progress across the entire program pathway. A strong monitoring and evaluation system relies on diverse and reliable data sources. Routine health management information systems provide continuous data from facilities, though they may suffer from issues of completeness or accuracy. Large scale national surveys like the NFH's that is National Family Health Survey, district level household surveys like DLHS, and sample registration system, which we call in short as SRS, provide more robust and representative data at periodic intervals. Special evaluation studies may be commissioned to examine particular aspects of the program in depth. Increasingly, community based monitoring and participatory approaches are being used to bring in the voices of beneficiaries. Triangulating these sources provides a richer and more credible picture of program performance. The Health Management Information System or HMIS is the backbone of routine monitoring in India's health sector. It gathers data from health facilities on a wide range of service delivery indicators, such as antenatal visits, institutional deliveries, and immunization coverage. Because the data is collected regularly, it allows program managers to track trends in near real time and make timely decisions. HIMS also supports supervision and performance appraisal at different levels of the health system. However, while HMIS is valuable for monitoring, its data may not always be reliable for evaluation due to issues like underreporting, overreporting, or poor quality data. Strengthening HMIS is a critical need of the hour. Large scale national surveys complement routine monitoring by providing robust evaluation data. The National Family Health Survey The National Family Health Survey is particularly important as it measures a wide range of reproductive, maternal, newborn, and child health indicators along with nutrition and family planning. The district level household survey, though less frequent, has provided direct, specific coverage information. The sample registration system continually tracks birth and death rates, serving as the most reliable source of maternal mortality indicators. Together, these surveys provide representative evidence that allows policymakers to judge the program effectiveness, compare different regions, and set realistic targets. In practice, National Family Health Survey, which is held after every 5 years, supplies rich disaggregated estimates by sex, age, caste, tribe, religion, wealth, quintile, and urban rural residents to surface inequities in reproductive and child health. SRS releases annual bulletins and cause of death studies, enabling trend analysis for infant mortality rate, neonatal mortality rate, and maternal mortality ratio. DLHS and similar district surveys help validate the coverage of antenatal care, institutional delivery, postnatal care, and full immunization, where routine health management information systems data are weak. Triangulating this NFHS, DLHS, and SRS with HMIS, Civil Registration System, Public Financial Management System, and Logistics Management Information System turns survey findings into actionable planning and budgeting. Small area estimation methods can downscale surveys signals to blocks for targeted supportive supervision of ANMs, PHCs, primary health centers. Small area estimation methods can downscale survey signals to blocks for targeted supportive supervision of ANMs and primary health centers. These databases also anchor sustainable development goals, tracking, and midterm reviews linking outcomes to resource allocations. Limitations are recall bias, sampling error for rare events, and time lags, and should be acknowledged with course corrections guided by both surveys and real time dashboards. Finally, promoting open microdata use, example demographic and health survey files, and routine data to decision hurdles ensure that national evidence strengthens local RCH action. In addition to routine and national data sources, special studies are often conducted to evaluate specific interventions or to explore issues in greater depth. Baseline and endline surveys are common in externally funded projects to measure change over time. Independent evaluations, often carried out by universities or research institutes, provide an impartial assessment of program performance. Operations research identifies practical problems in implementation and tests solutions in real world settings. In depth case studies provide qualitative insights into the community perceptions or barriers. These special studies enrich our understanding and provide actionable recommendations for improving RCH program. While quantitative indicators tell us how much progress has been made, qualitative methods help us understand why results are or are not being achieved. Focused group discussions and in depth interviews with beneficiaries, health workers, and community interviews with leaders provide nuanced insights into perceptions, barriers, and enablers. Observations of service delivery can reveal gaps in quality or inequality that numbers alone may miss. Community scoreboards and social audits give communities a direct role into evaluation of these programs. By blending qualitative and quantitative approaches, we arrive at a more holistic picture of the program performance and community satisfaction. Baseline and endline surveys are common tools for evaluating program effectiveness. A baseline captures the situation before an intervention begins. For example, levels of antenatal care coverage or contraceptive use in the community. The endline survey repeats the measurement after the intervention and tells us the impact, like what change was brought about in the community after the intervention was applied in that community. Comparing the two allows us to assess change and attribute it, at least in part, to the program. This before and after approach is particularly useful for donor funded projects or pilot programs where concrete evidence of impact is required. However, one must be cautious as changes may also be influenced by external factors. Good monitoring and evaluation depends on good data, and data quality is often the weakest link. Completeness means that all facilities and all services are reporting fully without any gaps. Accuracy refers to correctness. Data should reflect the reality on the ground without exaggeration or underreporting. Timelessness is essential because delayed data loses its utility for decision making. Consistency ensures that the same definitions and methods are used across time and regions. Data quality issues can severely undermine the credibility of monitoring and evaluation, and therefore, systematic checks, audits, and capacity building for data management are necessary. Now, triangulation. Triangulation means using multiple data sources and methods to validate the findings. For example, HMIS data for institutional deliveries can be cross checked with NFHS survey results and supplemented by qualitative interviews with mothers. This approach compensates for weaknesses in individual sources or provides a more balanced and credible picture. Triangulation also enables richer analysis by combining numerical trends with human experiences. In RCH, where programs are complex and data may be contested, triangulation is essential to building trust among the stakeholders and ensuring evidence based decisions. Participatory monitoring activity involves community members in tracking program activities and outcomes. Rather than being passive recipients, beneficiaries become partners in evaluation. Tools like community monitoring groups, village health committees, and participatory scoreboards give people a direct voice in assessing the services. This approach empowers communities and administrators. For example, when communities track drug availability or immunization sessions, it pressures the system to perform better. Participatory monitoring not only improves programs but also strengthens the social contract between the citizens and the health system. Community scorecards. They are a powerful participatory tool used in RCH programs. They are simple, visual representations where community members are the quality. They are the simple visual representations where community members rate the quality of health services, such as availability of staff, cleanliness of facilities, or behavior of providers. These scores are then shared in a joint meeting between the community and the service providers. The dialogue generates solutions and commitments for improvement. By, institu- by, institution, in, by institutionalizing community feedback, scorecards transform evaluation from a top down process into a collaborative problem solving exercise. This not only improves services but also fosters trust between the providers and the communities. Several success stories illustrate the value of strong monitoring and evaluation. In Tamil Nadu, maternal death audits helped identify causes of maternal mortality and led to targeted interventions, contributing to dramatic declines. In Gujarat, evaluation of Chiranjeevi Yojana, a public private partnership scheme for institutional deliveries, provided insights and that shaped scaling up. At the national level, NFH's findings on child malnutrition and anemia triggered significant policy reforms and intensified focus on nutrition under ICDS and Poshan Abhiyan. These examples demonstrate how effective monitoring and evaluation not only monitors program but also influences the national health policies. Despite its importance, monitoring and evaluation in RCH faces many challenges. Data quality remains a major concern, with underreporting, incomplete records, and inconsistencies undermining credibility. Many health staff lack adequate training in data collection and analysis. Funding for monitoring and evaluation is often insufficient, as it is seen as an overhead rather than an investment. Political interference sometimes distorts reporting to show exaggerated success. Moreover, even when data is collected, even when data is collected, it is not always used effectively for feedback and improvement. Overcoming these challenges requires a strong institutional commitment, capacity building, and a culture that values evidence. To overcome these challenges, several strategies are needed. Strengthening data systems through digitalization, standardization, and regular audits can improve quality. Building capacity of health workers and managers in data collection, analysis, and interpretation ensures better performance. Allocating adequate funding for monitoring and evaluation activities recognize their centrality to program success. Perhaps more importantly, promoting a culture of data use, where information is not just collected but actively applied in planning and supervision, can make monitoring and evaluation meaningful. Success stories from the state of Gujarat, Tamil Nadu that invested in these areas show that improvements are possible. Technology is revolutionizing monitoring and evaluation in health programs. Digital health programs integrate data from multiple sources and make it available instantly. Real time dashboards allow managers to track coverage indicators and performance in an accessible visual format. Mobile based reporting enables frontline health workers to enter data directly from the field and reduces delays and errors. Data visualization tools help in presenting complex data in an understandable way, supporting quick decision making. In RCH, where rapid response is often crucial, technology can greatly enhance the timelessness and accuracy of monitoring and evaluation. Monitoring and evaluation in family planning programs requires a mix of service delivery and behavioral indicators. Tracking contraceptive uptake rates helps assess coverage. Monitoring stock availability ensures there are no supply chain disruptions which can seriously undermine the program continuity and credibility. Evaluation should also assess the quality of counseling provided to clients, as informed choice and satisfaction are central to the reproductive rights. Combining quantitative data on usage with qualitative feedback from clients provides a comprehensive understanding of program performance. Family planning, monitoring, and evaluation thus illustrates the multi-dimensional nature of evaluation in RCH. In maternal health, monitoring indicators like institutional delivery rates and antenatal care coverage are fundamental. Maternal death reviews, which involve analyzing each death to identify preventable factors, are a crucial evaluation tool. Availability and quality of emergency obstetric care services must also be assessed. Together, these indicators provide a picture of both access and quality. When systematically implemented, maternal health monitoring and evaluation not only tracks performance but also guides targets interventions such as deploying skilled staff in high risk areas or strengthening referral systems. Child health monitoring focuses on immunization coverage, incidence of vaccine preventable Child health monitoring focuses on immunization coverage, incidence of vaccine preventable diseases, and nutritional status indicators such as stunting, wasting, and underweight prevalence. Evaluations also look at under 5 mortality and neonatal mortality rates. These outcomes reflect the cumulative effect of multiple interventions like immunization, breastfeeding promotion, nutritional supplementation, and disease control. Monitoring and evaluation in child health thus requires integration of data from diverse programs. The insights gained help in prioritizing strategies such as intensifying immunization drives or strengthening nutrition interventions in vulnerable areas. Monitoring and evaluation of RCH programs are directly linked to Sustainable Development Goals, especially Goal 3, which aims to ensure healthy lives and promote well being. Targets such as reducing maternal mortality to less than 70 per lakh live births, ending preventable deaths of newborns and under 5 children, and ensuring universal access to family planning require role of monitoring and evaluation. Without accurate monitoring, it would be impossible to know if we were on the track to meet these global commitments. Evaluation helps us understand not only the progress but also what strategies are most effective in different contexts. Looking beyond India, there are vulnerable international experiences in Looking beyond India, there are valuable international experiences in monitoring and evaluation of reproductive and child health programs. Rwanda, rewarded for achieving service targets, leading to improved maternal and child health indicators. Sri Lanka institutionalized maternal death surveillance and response, which contributed to its remarkably low maternal mortality. Malawi pioneered community health scorecards, giving citizens a direct role in holding providers accountable. These best practices highlight that strong monitoring and evaluation is possible even in resource constrained settings where there is political will, innovation, and community engagement. Building on these, Rwanda paired performance based financing with independent verification and quarterly audits and allowed the facilities to reinvest bonuses in staffing, transport, and small equipment, boosting of this caused the boosting of institutional deliveries and antenatal care completion. Sri Lanka's MDSR mandates notification within 24 hours, confidential inquiries, near miss reviews, and district action plans with timelines and responsible officers, turning every death into learning. Malawi's scorecards used community meetings and interface sessions to co create solutions and to monitor follow through publicly. Ethiopia integrated data used into routine supportive supervision and district health information software dashboards, improving completeness and timelessness of reports. Cross cutting lessons include aligning incentives with quality, applying equity weights for hard to reach populations, and publishing simple dashboards for transparency. Adapting these to India could mean piloting equity weighted PBF for primary health centers and community health centers, strengthening maternal and perinatal death surveillance and response, and institutionalizing community scorecards through the village health sanitation and nutrition committees. Finally, linking results to the public financing management systems and logistics management information systems would anchor incentives in verifying data and sustain improvements over time. Finally, linking results to the public financial management system and logistics management information system would anchor incentives in verified data and sustain improvements over time. The future of monitoring and evaluation in RCH will involve greater integration across programs so that maternal, newborn, child, and adolescent health data are analyzed together rather than in silos. Digital tools will be used more widely for real time data collection and analysis. There will also be increased emphasis on equity analysis, ensuring that progress is not only overall but also fair across the social groups. Strengthening of feedback systems so that findings are rapidly translated into action will be critical. These directions promise to make monitoring and evaluation not just a reporting exercise but a driver of continuous improvement in health outcomes. To summarize, monitoring and evaluation are essential pillars of effective reproductive and child health programs. They ensure accountability, track progress, identify gaps, and provide evidence for decision making. The logic model framework helps us systematically measure inputs, processes, outputs, and outcomes and impacts. Reliable data comes from multiple sources, including HMIS, national surveys, special studies, and community monitoring. While challenges such as poor data quality, limited capacity, and weak feedback loops remain, they can be overcome through stronger systems, investment in human resources, use of technology, and cultivation of a culture where data drives decisions. In conclusion, monitoring and evaluation are not peripheral activities but central components of program success. They allow us to move from intentions to results, from expenditure to impact. In this context of RCH, where lives of mothers and children are at stake, strong monitoring and evaluation can mean the difference between success and failure. By building robust systems, investing in people, leveraging technology, and fostering participation, we can make monitoring and evaluation a true engine of improvement. Let us remember that every number represents a life and every evaluation is an opportunity to do better with that life. With effective monitoring and evaluation, we can ensure that our programs genuinely advance the goal of health for all. So, this is all in this lesson today. And next, we take up lesson number 21, challenges and gaps in RCH service delivery. Thank you.